Hi, welcome back. Dr. John Kirk again from St. Helena Women's Health Center. We are talking about hormone replacement. What is hormone replacement? Well, it's the idea of giving somebody products, hormones, that they have less than they probably need. These hormones are typically for women, although men also receive hormone replacement. They're typically for women, and they usually involve 3 hormones, and primarily 2 of those 3. The 3 hormones are estrogen, progesterone, and testosterone. And they are present in both men and women, certainly not to equal degrees. The reason men have extra hair and deeper voices and tend to have fatter bellies are because of testosterone. Testosterone is a hormone that is a sex drive hormone. It has a great deal of effects throughout all of the cells of the body, and it is an effect in both women and men. But the real culprit for menopause and hormone replacement, and that which we talk about in the news, are estrogen and progesterone replacement. So hormone replacement therapy, HRT, reflects usually estrogen and progesterone and giving that back in some amount to physiologically affect women to help them get through the symptoms that they have as they approach and go through perimenopause and menopause. Hormone replacement has gone through a number of changes in terms of its perception over the years. Initially, it came out about 50 years ago with the advent of premarin. Premarin is probably well known to many of you out there. The younger you are, probably the less you know about premarin. The older, perhaps you know more. Well, what is premarin? Premarin is an interesting drug. It is manufactured by extracting the hormones from the urine of pregnant mares. Pregnant mares are horses, right? So premarin. Pretty interesting. So actually when you're taking premarin or that product, you're taking hormones that have been synthesized, extracted from a horse. That doesn't make us horses, it doesn't make any of you horses, it's just one way to distribute estrogen, and it was a cost-effective way. It's been proven to be reasonably safe, but what we realized after they started using it willy-nilly, thinking it was the wonder drug, all of a sudden women started having atypical bleeding and problems with that. And we realized if we didn't give progesterone, which is sort of the antidote to too much estrogen, if we didn't give progesterone, women ended up having uterine cancer to a significant greater result or extent than women who didn't use estrogen. Once we realized that we could keep that in check by giving back progesterone to sort of, in a sense, estrogen, think of it as a fertilizer. It grows things. That's its job. It's a growth factor. And one of the things it grows is the lining inside the uterus, the same lining that comes out every month in a menstrual period. Well, if you are growing with lots of water, lots of estrogen, and you're growing and growing and growing, at some point it's going to stop growing, it's going to break off, it's going to bleed, and sometimes it grows so much that it actually becomes atypical or cancerous. That being said, progesterone is kind of like mowing the lawn. So we give you progesterone and it goes in and it kind of keeps the growth at bay. It keeps it in check. And we found that it actually makes it the same in terms of cancer risk as if you weren't even taking the medicine at all as it relates to the uterus. So we went through a number of years of happy-go-lucky times with hormone replacement, with premarin. We added Provera was the brand name. It is a progestin, a type of progesterone that then would minimize the risk of uterine cancer. So we went through that, came out with many, many different products, different brand names, similar in some cases, and others were not. Others were synthesized. So-called bioidentical hormones, for example, is something that is a big part of hormone replacement therapy, and it's something that's talked about a great deal in the news. We'll probably do another topic on that because it's a bigger topic than I have time for today. But it's important to know, very important, there is no data that tells us that bioidentical hormones are safer than any other hormones that we get. There's simply no data. And anyone that tells you that there is, tell them to show you. But at the end of the day, the fact is it doesn't mean it's less safe, although the FDA believes they are, and they have their own reasons. The FDA is the Food and Drug Administration. But at the end of the day, well-prescribed and controlled, tailored medications that are given to you as an individual through your doctor are the right approach for you. So in other words, it's not up to me, it's not up to someone else, it's up to you as to whether or not you want to start or think about using hormone replacement. There are risks to hormone replacement, as there are risks to anything else, as I've talked about here before. Anything you do in life carries some level of risk. There's no free lunch. But for the most part, continuing hormone replacement at the time that you have the symptoms in the late 40s, mid to late 40s typically, or right after menopause, is a very reasonable thing with relatively low risks. One of the studies that we'll talk about in another segment is called the Women's Health Initiative, the WHI, and that actually changed the face of hormone replacement as we know it in 2006. We'll talk about that in some detail in that future segment, but just briefly, it basically said that women who took hormones, specifically premarin and provera, that's the progesterone, called a progestin, provera, and the estrogen, or premarin, those women who took that and had a uterus, they had more risks. They had more risks that we didn't even think they would. They had more risks of breast cancer, and they had more risks of cardiovascular disease. In fact, we thought it would actually lead to less cardiovascular disease. It didn't. Long story short, that study, though a very good quality study, it isn't really as pertinent when you really delve into it as we thought. Why? Primary reason is those women in that study, and there were 16,000 women in that particular arm of the study, those women were 63 years old on average, and they had been off of hormones and then restarted on hormones several years later after the menopause. That's not what's typically done. You don't go for 10, 12 years and then start hormones again. In most cases, you continue them as the symptoms start. So when we've looked at the data much more carefully, those women who in the mid-40s, early 50s, who were just starting the menopause, those women actually did not have an increased risk of breast cancer. In fact, they had a less risk of breast cancer. Wasn't statistically significant in that group, but it was interesting to note. Also, they had less risk of cardiovascular disease, and that was statistically significant. But it wasn't what they were looking for in the study, and so it just didn't rise to fill the news media with all of that good positive when you had that negative stuff to talk about with that for the first part of the study I talked about in breast cancer risk. So long story short, there's been a few studies since then, and we'll talk about those again in future segments, but the long and short of it is, we believe low doses, the lowest that's necessary to solve the problems that you have for a short period of time, the shortest period of time that's necessary to solve the problems that you have, is a reasonable approach to hormone replacement. But it's tailored, it's for you as an individual working in concert with us, your provider, and we would love to help you get there. Whatever we can do, let us know, we'll help you. Dr. Kirk signing out from St. Helena Women's Health Center. Have a blessed day.